Assalamu alaikum wa rahmatullahi wa barakatuh. Our seminar today is about malabsorption syndrome, presented by me, Amina Hasan, and my friends Ayesha Qahtan, Taghreed Thamir, and Ayesha Hussain, supervised by Dr. Karam Turath. We beginning with the definition and the classification. What we mean by malabsorption syndrome is characterized by impaired intestinal absorption of a nutrient, especially of fat. Some other substances are proteins, carbohydrates, vitamins, and minerals. We subdivided malabsorption syndrome according to the causes of the disease into primary and secondary. What about primary malabsorption syndrome, which is due to primary deficiency of the absorptive mucosal surface and of associated enzymes? The common type of primary malabsorption syndrome are: the first one, celiac disease; the second one, tropicus-pro; the third one, Whipple disease; and the last, disaccharidase deficiency, lactase deficiency. Now, the secondary malabsorption syndrome, in which mucosal changes result secondary to other factors such as disease, surgery, trauma, and drugs. Cystic fibrosis, bacterial overgrowth, beta-lipoproteinemia, these are the common type of secondary malabsorption. Signs and symptoms of malabsorption syndrome: weight loss due to malabsorption of the nutrients; diarrhea due to impaired absorption of water and electrolyte; hypotension; bone pain because malabsorption of vitamin D and calcium; anemia due to vitamin B12, iron, and folate malabsorption. Other symptoms are anorexia, abdominal distension, and muscle wasting. How we can diagnose the malabsorption syndrome? We can do this by two ways. The first one, laboratory test according to the type of the disease. Some examples of the tests are blood lipid level test and fecal analysis for fat malabsorption. Other, lactose tolerant test and bile acid breath test for carbohydrate malabsorption, and so on. The second way for diagnosis the malabsorption syndrome is the biopsy. Mucosal biopsy of a small intestine is essential for making the diagnosis of the malabsorption syndrome. It shows presence of villus atrophy varying from partial to near total. Now, the celiac disease. My friend Aya will continue.
Assalamu alaikum. I am Ayesha Qahtan. I will talk about primary causes of malabsorption syndrome. I begin with celiac disease. Celiac disease, sometimes called celiac-pro or gluten-sensitive enteropathy. It is an immunologically mediated enteropathy caused by a permanent intolerance to ingested gluten in genetically excitable individuals. It is triggered by interaction between environmental, genetic, and immunological factors. What about the pathogenesis? When somebody with celiac disease eats a diet containing gluten, it is broken down in the stomach into gliadin. After that, in the small intestine, this gliadin passes from the epithelial surface into the lamina propria. Once there, an enzyme called tissue transglutaminase cut off its amide group from this protein to form deamidated gliadin that is eaten up by a macrophage and served up on its MHC class II molecules. T helper cells recognize this antigen that is expressed by antigen-presenting cells and begins to release cytokines that cause villus atrophy, crypt hyperplasia, and intraepithelial lymphocytosis. T helper cells also activate B cells to release antibodies such as anti-gliadin, anti-endomysial, and anti-tissue transglutaminase. This histological pictures taken from the duodenum shows subtotal villus atrophy, crypt hyperplasia, and intraepithelial lymphocytosis. And there is total villus atrophy. Clinical manifestations of celiac disease vary according age group. In infant and young children, it is present with diarrhea, abdominal distension, and failure to thrive. However, vomiting, irritability, anorexia, and even constipation are also common. In older children and adolescents, it often presents with extra-intestinal manifestations, such as short stature, neurologic symptom, or anemia. Among adults, 2 to 3 times as many women have the disease as men. The classic presentation in adults is diarrhea, accompanied by abdominal pain or discomfort. And other silent presentations in adults include iron deficiency anemia and osteoporosis. What's about the diagnosis? Firstly, by the serological test, we can detect immunoglobulin A and immunoglobulin G anti-gliadin antibodies, immunoglobulin A and immunoglobulin G tissue transglutaminase antibodies, and anti-reticulin antibodies. Second, by the genetic test, we can detect HLA-DQ2 and HLA-DQ4 marker in more than 90% celiac disease patients. And lastly, by histopathology, the definitive test is a small intestinal biopsy taken endoscopically. The proximal duodenum is maximally affected. It shows subtotal or total villus atrophy with intense inflammatory infiltration. The other causes of primary malabsorption is tropical sprue. What is the definition of tropical sprue? Tropical sprue is an acquired intestinal malabsorption syndrome of unknown etiology affecting resident and tourists of tropical region. The exact etiology of tropical sprue remains unknown, but it has suggested that persistent infection may be responsible, and it is also referred to as post-infective tropical malabsorption. Klebsiella, E. coli, and Enterobacter species are the usual organisms associated with tropical sprue. What's about the pathophysiology? Nutrient malabsorption in tropical sprue areas from villus blunting of both proximal and distal small intestine that can be distinguishable from celiac disease. In addition, there is also crypt hyperplasia with intraepithelial lymphocytosis, contributing to reduction in total absorptive surface area. Reduced absorption of carbohydrates, fats, and fat-soluble vitamins, iron, and folate represent proximal small bowel involvement, whereas vitamin B12 and bile acid malabsorption indicate terminal ileum involvement. And this histological pictures shows the main difference between tropical sprue and celiac disease. Firstly, in tropical sprue, we can see the shortening and the blunting of the villi, whereas in celiac disease, we can see subtotal or total villus atrophy. And in both celiac disease and tropical sprue, we can see crypt hyperplasia and intraepithelial lymphocytosis. What's about the clinical manifestation? Typical patients come with chronic non-bloody diarrhea, weight loss, bloating, and abdominal cramps. Patients may have pallor due to anemia, angular stomatitis, and cheilitis due to vitamin B12 deficiency, or other features of vitamin or nutritional deficiency. How we can make the diagnosis? Laboratory tests may reveal megaloblastic anemia due to vitamin B12 and folate deficiency, in addition to the level of other vitamins, such as vitamin A and vitamin D. Upper endoscope show normal mucosa, but small bowel biopsy show intraepithelial lymphocytosis and the blunting of the villi. I will let my friend Taghreed continue talking about other causes of primary malabsorption.
Assalamu alaikum everyone. My name is Thamir and I'll talk about the Whipple disease, a part of the malabsorption syndrome. Firstly, we should know what is the Whipple disease. It's a rare bacterial infection that most often affect gastrointestinal system that interface with the normal digestion by impairing the breakdown of the food such as fats and the carbohydrates, and thus affecting the body's ability to absorb nutrient. So, the Whipple disease primarily causes malabsorption syndrome because the mucosal lining of the small intestine is targeted and small lesions within the intestinal wall form. It also can affect other organs such as brain, heart, joints, and eyes. What are the causes of the Whipple disease? The root cause of the Whipple disease is the bacterium Trophilema whipplei. This bacterium affects the mucosal lining of the small intestine in the beginning, resulting in the formation of the small lesions in the intestinal wall. This bacterium also causes damage to the villi of the small intestine. What are the risk factors of the Whipple disease? Whipple disease is more common in the middle age and the older individuals. It's common in the men than women. It's common in the farmers and those exposed to the soil and the animals, suggesting that the infection is excluded from this source. It's less common in children and seen mostly in the adults between the age group of 40 and 60, in Caucasian patients, and in some cases the bacterium is already present in the body, but Whipple disease occurs due to the hereditary factors or presence of the HLA-B27 antigen. This figure shows the pathogenesis of the Whipple disease, and it is very important for the diagnosis. The cytoplasm of the macrophages in the Whipple disease contains intensely PAS positive material in the RO that is coarsely granular. What are the symptoms of the Whipple disease? Gastrointestinal signs and the symptoms are common in the Whipple disease and may include diarrhea that have excessive amount of the fat in the stool, abdominal cramping and the pain which may worsen after meals, weight loss due to the malabsorption in nutrient, joint inflammation, anemia with the weakness and the fatigue due to the inadequate absorption of the vitamin B12, iron and the folic acid, gout, fever, enlargement of the lymph node in the abdomen, hyperpigmentation of the skin due to the vitamin B3 deficiency, vitamin B12 deficiency, or low cortisol level, chest pain, and splenomegaly. How is Whipple disease diagnosed? Number 1, physical examination by look for any indicator that may suggest Whipple disease, like abdominal tenderness or hyperpigmentation of the skin. Number 2, biopsy of the tissue of the small intestine and examined under microscope. In the biopsy, the presence of the only bacteria in the sample doesn't indicate Whipple disease, so the macrophages should also be abnormal to confirm the diagnosis. Number 3, blood test. In the blood test, serum protein, albumin, and the carotene level decrease due to the malabsorption, electrolytes decrease due to the dehydration that occur due to the vomiting and diarrhea, and the red blood cells and the iron decrease due to the anemia. And finally, by the stool test. In the case of the Whipple disease, the stool have excessive amount of the fat content. Now, I'll talk about the lactose intolerance, a type of the malabsorption syndrome. What is the lactose intolerance? It's the inability to break down a type of the natural sugar called lactose that is commonly found in the dairy products such as milk and the yogurt. What are the causes of the lactose intolerance? A person becomes lactose intolerant when his or her small intestine stops making enough of the enzyme lactase that digest and break down the lactose into galactose and the glucose. When this happens, the undigested lactose moves into the large intestine or colon, the bacteria that are normally present in the large intestine, and this bacteria interacts with the undigested lactose. So, this condition may also be called lactase deficiency. This video shows the causes of the lactose intolerance. Firstly, a glass of the milk contains 11 grams of the lactose. To be absorbed and used by the body, must be broken down into glucose and the galactose by the lactase enzyme, and this enzyme found in the small intestine. Normally, the food that contains lactose moves into the small intestine, and this lactose composite of the galactose and glucose. And when the lactose arrives the small intestine, will be digested by the lactase enzyme that is found in the small intestine and break down into galactose and glucose, so easily absorbed by the small intestine. In lactose intolerance, the small intestine stops making enough of the lactase enzyme that digests and break down the lactose into the galactose and the glucose. So, the undigested lactose will move into the large intestine or colon. And the large intestine have normally bacteria. And the bacteria interacts with the undigested lactose. So, increase motility, floatance, and abdominal cramp. What are the symptoms of the lactose intolerance? The symptoms mostly occur within the 30 minutes to the 2 hours after you eat dairy products, including stomach pain, cramp, full steam, nausea with the vomiting, and diarrhea. Symptoms in the young children may be slightly different, such as diarrhea with the bubbles, develops slowly, occasionally vomiting, and dermatitis. What are the risk factors of the lactose intolerance? The lactose intolerance is more common in the older adults than infants and the young children. It's most common in the Black Asian, Spanish, and the American. Babies with the preterm delivery have the potential to reduce the lactase level, as this enzyme increases in the late fetus in the third trimester. How is lactose intolerance diagnosed? Number 1, physical examination by look for any indicator that may suggest lactose intolerance, such as abdominal cramp, diarrhea with the bubbles and the floatings, nausea with the vomiting, and other symptoms. Number 2, hydrogen breath test is a simple way of determining if you be lactose intolerant. You will be asked to avoid eating or drinking during the night before the test. When you arrive for the test, you will be asked to blow up a balloon-like bag. This sample of your breath will be tested to find out how much hydrogen is present, and then will be given a drink of the lactose solution. And your breath will be tested every 15 minutes over the next few hours to see if the level of the hydrogen change. If your breath contains a large amount of the hydrogen, more than 20 parts per million above your baseline, it's likely that you are lactose intolerant. And now I let my colleague Ayesha to continue.
Welcome everyone, I am Ayesha Hussain and I will talk about secondary malabsorption. In addition to primary malabsorption syndrome which mentioned by my colleagues, malabsorption can occur secondarily either due to impaired digestion such as in cystic fibrosis or maybe due to impaired absorption as we see in small intestinal bacterial overgrowth or maybe due to impaired transfer such as in beta-lipoproteinemia. To start talking about cystic fibrosis, we should know what is cystic fibrosis. So, cystic fibrosis is a disorder of epithelial ion transport affecting fluid secretion in the exocrine gland and the epithelial lining of respiratory, gastrointestinal, and reproductive tract. It is an autosomal recessive inherited disease caused by mutation in cystic fibrosis transmembrane conductance regulator gene, which is also abbreviated as CFTR gene. Mutation of this gene resulting in an impaired function of ion transporting channels with accumulation of thick mucus. And this figure shows normal channel to the left side, the chloride ion can pass easily to the outside of the cell, whereas to the right side we have a mutant channel due to the mutant gene. Chloride ion cannot move and this results in sticky mucus to build up outside of the cell. Pathophysiology. In addition to respiratory and genital tract pathogenesis, individuals with cystic fibrosis have a defect in the intestinal and pancreatic ductal ion transport. This abnormality interferes with bicarbonate, sodium, and water secretion, resulting in inadequate luminal hydration with the mucus formation. In the pancreas, The ducts are plugged with thick mucus, resulting in an obstruction of the pancreatic duct with a retention of the pancreatic enzyme and low-grade autodigestion of the pancreas and eventual exocrine pancreatic insufficiency in more than 80% of the cases. This pancreatic insufficiency leads to protein and fat malabsorption, which result in bulky, foul-smelling stool in addition to loss of fat-soluble vitamins. Bile also can affect it and become stickier than normal, causing irritation and inflammation in the ducts and potentially obstruction of bile duct by formation of gallstone. Liver also can affect it, either due to impaired drainage of the bile out of the liver or maybe due to scarring and fibrosis. Impaired water secretion by intestine lead to thick mucus and finally obstruction of intestinal lumen. This figure shows abnormal histology in the pancreas with patient with cystic fibrosis, where is the duct abnormally dilated and filled with eosinophilic mucin. The parenchymal gland also undergo atrophy and replaced by fibrous tissue. The symptoms can start as early as infancy, while in other cases, person does not experience any symptoms until adulthood. However, in a newborn, vesicousiluminal content may result in meconium ileus, which means no bowel movement in the first 24 to 48 hours of newborn lives, and this occurs in 10% of cases with delayed of growth. GIT symptoms include foul smelling with a greasy stool, as we said, due to fat malabsorption with poor weight gain, in addition to respiratory symptoms. The diagnosis can be done by making a blood test to check for higher level of chemicals related to pancreas. Sweat test important to detect high salt level in patient sweat. Also, we have an important genetic test to check the defective gene, in addition to sputum culture, imaging test, and lung function test. Another cause of secondary malabsorption is abeta-lipoproteinemia. What is abeta-lipoproteinemia? Is a rare autosomal recessive disorder characterized by an inability to secrete triglyceride-rich lipoprotein. What about pathophysiology? Starting from normal physiology, we have an important microsomal triglyceride transfer protein, which is a major cellular protein capable of transferring neutral lipid between membrane vesicles. It is rule essential for biosynthesis of apolipoprotein beta, which is the major structural component of chylomicron, very low density and low density lipoprotein in both liver and intestine. So, mutation of this microsomal protein will lead to failure of this transferring process and eventually failure of lipoprotein production. As a result, monoglyceride and triglyceride accumulate within the epithelial cell. And this figure shows enterocyte with a clear cytoplasm due to lipid accumulation. Most of the clinical pictures of this disease result from severe deficiency of fat and fat-soluble vitamins, especially vitamin E. Starting from infancy, GIT symptoms begin and patients come with diarrhea with the losing of fat and fat-soluble vitamin with the stool, as we said. Hepatic manifestation include hepatomegaly due to hepatic steatosis, and cirrhosis can occur in some patients. Hematological picture include acanthocytosis, which is the hallmark feature of disease due to defective phospholipid cell membrane, resulting in low circulating RBC and eventually anemia. Bleeding tendency may occur also due to vitamin K deficiency. Demyelination leads to peripheral neuropathy and other neurological manifestation. Patients come with weakened muscle. Night blindness also can occur due to vitamin A deficiency. The diagnosis include stool sampling and intestinal biopsy. We have also blood smear to show acanthocytosis. This figure shows acanthocytosis, whereas the RBC abnormally spiked. Fasting lipid profile show decrease in total cholesterol and low density, in addition to very low density lipoprotein deficiency. Imaging studies include hepatic scan or ultrasound, in addition to MRI in the neurological involvement. However, these tests are not confirmatory. As the disease is rare, genetic test is necessary for diagnosis. This is all about our presentation, and thank you for your listening.